Hi, my name's Doris Christine Prasad, and today I will be presenting a critique of the 2014 to the 2016 Ebola virus outbreak. So what is Ebola virus disease? Ebola virus disease, which I will refer to as EVD from now on, is a severe and often fatal zoonotic illness caused by viruses within the Filoviridae family and the Ebola virus genus. It was first identified in 1976 near the Ebola River in what is now called the Democratic Republic of the Congo. There has been approximately 34 outbreaks that have been reported in Africa since its genesis. This has resulted in 6 distinct strains that have the ability to infect humans and other primates. EVD symptoms include fever, muscle pain, and chills, followed by vomiting and diarrhea. The condition can quickly deteriorate, leading to severe symptoms such as multiple organ failure and internal bleeding. Transmission. Bats are considered the primary reservoirs for EVD, with initial outbreaks in humans often occurring from contact with or consumption of infected bats, including their meat or bodily fluids. These bats carry the virus asymptomatically, which further impacts on the ability to recognize infectious levels. Person-to-person transmission occurs through close contact with an infected person or their bodily fluids, as well as through contact with contaminated surfaces and clothing from individuals who are infected or who have passed away from the virus. Additionally, traditional burial practices that do not follow safety protocols are a significant factor in spreading the disease. So this is an image of how the Ebola virus spreads from animal to animal, as well as from animal to person, and then person to person. Diagnosis. To consider Ebola disease as a potential diagnosis, there must be both a presence of indicative symptoms and a potential exposure to an Ebola virus within the 21 days preceding symptom onset. Possible exposures include contact with blood or bodily fluids from an individual who is ill or who has died from Ebola, interaction with objects that have been contaminated with the blood or bodily fluids of a person affected by Ebola, contact with infected fruit bats or non-human primates, exposure to the semen of a man who has recovered from Ebola disease. The most commonly used diagnostic test for EVD during the 2014 to 2016 Ebola outbreak was the use of the reverse transcription polymerase chain reaction test. This test is frequently used to diagnose Ebola disease due to its sensitivity in detecting low levels of the Ebola virus. A positive PCR test confirms infection for EBV. Other testing methods include the employment of the antigen capture enzyme linked immunosorbent assay and virus isolation by cell culture. The Ebola virus disease outbreak in West Africa began in December 2013 and went undetected for more than 3 months. Although the first medical alert was issued on January 24, 2014, the outbreak was not officially recognized until March 23, 2014. Additionally, it wasn't until August 8, 2014 that the situation was declared a public health emergency of international concern. This declaration was crucial as it prompted international financial and logistical support and raised the level of urgency to a global scale. The lack of initial response highlighted a gap in outbreak management. During the outbreak, it became widely recognized that Ebola can spread from human to human. However, the zoonotic source of the disease was less acknowledged. As the origin of the disease came from infected bats, bat migration was a potential factor in spreading viruses amongst the animal's population, as well as the possibility of increased interactions with humans. The outbreak drew significant attention to tracing human-to-human contacts during the early phases of the epidemic, but there was less focus on bat-to-human contacts, and even less attention given to animal health and environmental factors that may have influenced these interactions. The One Health concept recognizes that the health of people is closely connected to the health of animals and the shared environment. This approach is particularly relevant in managing zoonotic diseases such as EVD. The international health regulations serve as a crucial framework for enhancing global health security, designed to safeguard public health while minimizing disruptions to international traffic and trade. During the third IHR Emergency Committee meeting, it was deemed necessary that international meetings and mass gatherings were ceased. This maneuver allowed for a delay and reduction in international spread. The Joint External Evaluation is a voluntary collaborative process aimed at evaluating a country's ability to prevent, detect, and swiftly respond to public health threats. This tool will be used to critique the outbreak. With the technical area Prevent being highlighted as per the JEE tool, it was found that the initial and prolonged inability to control what was assumed to be a manageable disease served as a lesson for the global public health community. Many of the systems and institutions tasked with preventing, detecting, and responding to outbreaks were found to be inadequately prepared to function effectively and control the outbreak within a timely manner. The technical area Detect, according to the JEE tool, advises that there should be tier-specific diagnostic testing and adequate equipment in place. According to the study performed by Ellabrook et al., out of 28 datasets received from 21 laboratories, 23 showed optimal results, while 5 lacked sensitivity. With the assistance of the World Health Organization, this area was able to be maintained adequately. As per the JEE tool, prevention capacities were weak. EVD highlighted the deficiencies in the healthcare systems of the sub-Saharan African countries affected by the outbreak, emphasizing the absence of sufficient healthcare infrastructure to manage complex health emergencies in under-resourced and developing settings. There were also delayed detection capacities. The initial detection and laboratory confirmation of Ebola cases were delayed, leading to further spread of the disease. Delays in detecting initial cases of EVD after an initial transmission can lead to widespread and prolonged outbreaks, especially in areas with dense populations, extensive connectivity, and socio-political instability. Compliance with international health regulations. The EVD outbreak exposed gaps in the compliance and implementation of the IHR. Efforts to gather information from Sierra Leone, Liberia, and Guinea began late in the epidemic and rely on various organizations to submit data. However, due to the diverse formats of the data submitted, comprehensive information was not able to be obtained. Overwhelmed health system. A robust health system reduces a country's susceptibility to health hazards and enhances its readiness to lessen the effects of crises. Over the past 10 years, Guinea, Liberia, and Sierra Leone have received more health-related assistance from abroad. Much of this aid has been directed towards fighting HIV, malaria, and tuberculosis, with the remainder largely supporting maternal and child health services. As a result, only a small portion of the external aid was available for the broader development of health systems. Lessons learned. Community engagement is a fundamental component of epidemic readiness and response operations. Advanced medical technologies alone cannot effectively prevent and manage epidemics without substantial efforts to build trust within communities and to comprehend their views on control measures, which is crucial for addressing their needs more effectively. Frontline workers are to be thoroughly trained and supported with potential outbreaks. The public health workforce requires support from integrated service systems that encompass healthcare, laboratory, surveillance, and social services. It is vital for public health bodies to regularly assess our healthcare's population and the capabilities to ensure readiness. Early funding is also crucial for encouraging research and development on pathogens that pose epidemic risks. Although research on EVD started in the 1970s, no approved medications, vaccines, or rapid diagnostic tests were available at the onset of the outbreak in West Africa. From a One Health perspective, implementing comprehensive surveillance systems that monitor both human populations and wildlife, particularly in regions where animals are known reservoirs of the virus, is a fundamental step. Monitoring the health of animals allows for early detection and prevention. Rapid and coordinated international response. Delays in mobilizing international support and resources contributed to the spread of the disease. A coordinated international response is crucial to avert the extensive scale of the 2014 to the 2016 outbreak. Recommendations. Employment of systematic and consistent methods for community engagement that focus on two-way communication. This may include deploying community health workers to educate and monitor the health of the wider community, as well as engaging traditional and religious leaders to endorse health messages. Foster community engagement and education programs to combat stigma and improve health literacy. Implementing regular and timely mechanisms for capturing and reporting data monitored by the community. This can be done through the implementation of technology to allow community members to report suspected cases or unsafe practices via phone or text message. Consistent and up-to-date education in relation to outbreak and new diseases is another recommendation. Continuous refresher training to ensure that workers have up-to-date knowledge regarding disease. Strengthen mechanisms for international collaboration, including funding, logistics, and operational support during health emergencies, and reviewing and reinforcing legal and policy frameworks to ensure that they support rapid and effective public health responses and comply with the IHR. Challenges. Fear-related behaviours influenced the EVD outbreak of 2014 to 2016. Individuals during this time period refrained from seeking healthcare due to concerns about exposure within healthcare facilities. A national survey conducted in Sierra Leone in August 2014 found that 95% of respondents exhibited some form of discriminatory attitude towards Ebola survivors. 78% of those surveyed stated that they would not accept an Ebola survivor back into their community after recovering from the disease. Alongside the social stigma and fear that survivors felt, the healthcare workers who looked after Ebola patients revealed that they faced continuous discrimination when they attempted to reintegrate back into their communities. Cultural influences and the use of traditional medicines were seen to be another obstacle. Traditional burial rituals involving close contact with the deceased were halted to prevent further transmission from infectious corpses. This was replaced with medical burials led by trained Ebola healthcare workers. The World Health Organization reports that approximately 70 to 80% of the West African population relies on traditional medicines, for example, healing practices. A study by Hewlett noted that traditional healers in Uganda were reported to make incisions on bodies so medicinal application could occur. Due to the transmission of EVD being person to person via direct contact, this was prohibited in Sierra Leone during the later stages of the epidemic. These are my references. Thank you very much.